I'll be talking about chronic pancreatitis in this video. So, what is chronic pancreatitis? It is defined as a condition which is characterized by long-standing and progressive inflammation of the pancreas. Okay? Now, this progressive infection or inflammation of the pancreas leads to permanent alterations in the organ's normal structure and function. So it results in both impairment of exocrine and endocrine function, which results in malabsorption of fat-soluble vitamins like A, D, E, and K deficiencies, along with insulin deficiency resulting in diabetes. It's very commonly seen in alcoholism and is a common cause in the United States. The pathophysiology, there are various etiologies associated with pancreatitis, chronic pancreatitis. One of them is alcohol abuse, smoking, genetic causes like cystic fibrosis, ductal obstruction as a result of trauma or tumors, stones, and autoimmune pancreatitis, idiopathic pancreatitis, or tropical pancreatitis. The etiology or the pathophysiology of the chronic pancreatitis is not fully understood. So we will, some common causes could be ductal obstruction, ischemia, or due to lack of antioxidants like selenium, vitamin C, E, and methionine, and autoimmune mechanism. So these are possible pathophysiology of chronic pancreatitis. Now, how does patients present? Patients present with abdominal pain. Now, this abdominal pain, unlike acute pancreatitis, may be worse 15 to 30 minutes after eating, and patients get repeated pain attacks, and because it's a chronic condition. And this pain is epigastric, which radiates to the back, relieved by leaning forward. So it may be continuous or may be intermittent, okay, unlike acute pancreatitis, which is a continuous pain. Associated with nausea, vomiting, steatorrhea, flatulence, and constipation. This is an important distinction feature. And also, with physical exam will show weight loss. So how do you go ahead and diagnose chronic pancreatitis? So first thing is the diagnostic approach must primarily be based on clinical presentation and confirmed via either imaging or a secretin pancreatic function studies. Okay, so what are the imaging modalities you can use? Abdominal computed topography or CT scan with contrast, or you may do an MRCP. Now, MRCP is becoming the diagnostic test of choice. Why? Because of no risk of radiation. However, CT scan is, always the best initial imaging test. So, what do you find on CT scan of chronic pancreatitis? You may see calcification within the pancreas. There may be ductal dilation, enlargement of the pancreas, or fluid collections like pseudocysts adjacent to the gland. All right, then when do you do an ERCP? Well, ERCP has no indication in chronic pancreatitis unless there is a need of therapeutic intervention. What are the other tests that you may do? Serum amylase lipase, but that's going to be normal or to minimally elevation. This does not give you the diagnosis of chronic pancreatitis. CBC, electrolytes, and liver function tests, again, these are typically normal. And very important is HbA1c. You want to evaluate diabetes. All right, so what is pancreatic function test? You do a secretin pancreatic function test. So what happens following secretin is that there'll be increase in the level of bicarb. This is normally seen in pancreatic function. In case of chronic pancreatitis, when you give secretin, there will be low level of bicarb. Okay, so this indicates exocrine pancreatic insufficiency. In addition, you may also want to do a stool elastase. If less than 200, this means that there is pancreatic insufficiency. and low serum trypsinogen, which is less than 20 nanogram per ml. This also indicates pancreatic insufficiency. So that was the diagnostic approach. Then moving on to the treatment of chronic pancreatitis. So chronic pancreatitis management is multi-pronged and is aimed to target pain management. This is the main one, target pain management, okay? So the first line is always cessation of alcohol and tobacco, dietary modification. Now, what kind of dietary modification you will ask the patient to do? Eat small meals that are low in fat, that is important. And then acid suppression, example proton pump inhibitors, this is the most important one, along with pancreatic enzyme supplements. Example, lipase for pain management and malabsorption. This is important. And when you're giving pancreatic enzyme supplements, it does not mean that you're just compensating for malabsorption. It also helps in pain management, okay? And definitely vitamin supplementation, fat-soluble vitamins like A, D, E, and K, along with B12, and oral hypoglycemic agents for insulin therapy is also needed. The second line management of chronic pancreatitis is analgesics with opiates and or NSAIDs. We always want to avoid opiates in chronic conditions because it may lead to addiction, okay? So that is why these are second line. Analgesics with opiates and or NSAIDs is indicated in pancreatic enzyme therapy fails to control the pain, all right? An adjunct is pregabalin, which can also be used, also tricyclic antidepressants like amitriptyline, and other approaches for pain management include endoscopic therapy, extracorporeal shockwave lithotripsy, or celiac nerve block. Now, these are indicated only if the above doesn't work and is rarely done. Third line is surgery who fail medical management. Okay? And the chronic complications include chronic pain with addiction to analgesics. That's why I said that the analgesia or opiates are always second line following pancreatic enzyme supplement. And then exocrine and endocrine insufficiency, pancreatic pseudocyst, obstruction of the ducts, and increased risk of pancreatic cancer. So this was chronic pancreatitis summary. Now let's dig into a UWorld question. So here is a patient whose MRCP reveals scattered calcification within the pancreas without ductal obstruction, pseudocyst, or tumor. Fecal elastase level is low. He is counseled to cease alcohol use and continue to avoid alcohol. A low-fat diet with small, frequent meal is also recommended. Supplementation of fat-soluble vitamins is prescribed. Then the patient confirms his strong intention to follow all recommendations. Which of the following is the most appropriate next step in management of this patient's abdominal pain? We want to reassure the patient because as he promises to follow all the recommendation and then reassess of symptoms in 1 to 2 months. Okay, if the patient improves, that's good. He's responding to fat-soluble vitamins. If the patient is not responding, then you may add NSAIDs, opiates, depending on the patient's requirement. Okay, so here is the overview of pancreatitis from UWorld. Alcohol use, cystic fibrosis, ductal obstruction, autoimmune. These are the etiologies of chronic pancreatitis. Clinical presentation, as I said, chronic epigastric pain with intermittent pain-free intervals. This is distinctive from the acute pancreatitis. Also malabsorption resulting in steatorrhea, weight loss, and diabetes mellitus, maybe new onset. Lab findings, amylase, lipase may be normal and non-diagnostic. So the most diagnostic one is either CT scan or MRCP. Treatment would be pain management, alcohol and smoking cessation, frequent small meals, and pancreatic enzyme supplements. If patient doesn't improve with pancreatic enzyme supplements after reassessment of pain in 1 or 2 months, then you may switch to a trial of non-opioid analgesics such as tricyclic antidepressant amitriptyline, NSAIDs, and pregabalin. If that doesn't work, then you may shift to opioid analgesics Or if it fails, then you may start with celiac nerve block, and so on. So this is a general um, review of chronic pancreatitis. In addition, in regards to the diagnostic modality, MRCP is equivalent to abdominal CT scan. So if whatever is available, then you may go for either MRCP or abdominal CT scan. Abdominal CT scan is not favorable because of its radiation risk. However, both are diagnostic for chronic pancreatitis. Another thing is the presentation, abdominal pain. It radiates to the back. Now, this pain may be relieved by sitting up or leaning forward, positions that displace the other abdominal organs away from inflamed pancreas. And it may be episodic or continuous, or may be exacerbated by meals. So it's, it can look a lot like gastric ulcer. Okay, so in this case, you want to do a CT scan to rule out the possible differential diagnosis. Okay, so this is chronic pancreatitis. Thank you so much.